Good evening. Uh, my regards to all those who are present here. Why I call this old is gold is there has been a lot of discussion about the type of scleral fixated IOLs, about when you should do them, about when it is not supposed to be done, what happens to the rest of the ocular tissues, what about the inflammation, what about the vitreous, and will the SFIOL trigger any kind of additional inflammation after doing it. So I prefer to do the sutured SFIOL, wherein to make the side flaps just like we do in trab, I measure it with a caliper, mark the caliper with a marker pen so that it's easier to delineate the flaps here. I'll just run through this video and then create the flaps on either sides after measuring them so that they come out nicely. And then once the flaps are ready, I fashion the tunnel. I use a frown incision, so that's how I make the tunnel. Why is it not going ahead? Okay. So after the flaps are created on both sides, in this case, I had also done a vitrectomy and hence the pars plana vitrectomy infusion port is here. I measure the distance from, this is an ab externo technique, so where we measure the distance from the limbus. Here I pass the straight end of the needle and then through a handshake receive it into a 26 gauge needle from the other side. And then we bring it out. So in this process, we are not doing any kind of manipulation intraocularly. So the risk of inflammation is thereby reduced again here. After this, once the needle is out through the other side, then I pull out the suture using a McPherson or any suture holding forceps through the tunnel, clip it into two pieces, and then tie it onto the IOL, onto the eyelet of the regular SFIOL. Once it is tied on both sides, then we can grasp the IOL with either an iris claw grasping forceps or a McPherson, whatever we are comfortable with. Insert it inside the anterior chamber and carefully adjust the sutures on both the sides. In this technique, what happens is that since most of the procedures are done extraocularly, where that is suturing of the IOL, passing of the sutures and then cutting it, all that is done extraocularly. So the intraocular inflammation is very minimal, or rather absent unless we have touched the iris for any reason, like to release some synechae, or if we have had to do a PBI for any cause. Once this is centralized or centered in the pupillary space, then we can tie on either sides, and then this is done. So why? There have been many modifications of the SFIOL where a lot of people now prefer Yamane technique, there's a chariot technique, then there is a lot of glued IOL being done. But the latest technique, the Canabrava technique, where he uses 4 flanges, can also be done for this similar technique. In this technique, what it does is where we suture the IOL in the classical case, he uses a thicker suture, a 5-0 or a 6-0 nylon, polypropylene, and that with the ballpoint cautery or a heat cautery, it's made into a dumbbell which again locks into the eyelet. What I feel is there have been a lot of studies comparing this glued IOL versus the Yamane technique and which one is better and which one is less. But honestly, there has not been an unbiased study comparing a classic old sutured SFIOL versus the more efficient or lesser handling techniques like the Canabrava technique. So perhaps if we can take on a multi-center study where we do compare all these cases in clean cases where the surgeon is sure that there has been no complicated cataract surgeries which led to performing the SFIOL, perhaps we can get more unbiased results. Hoffman pockets instead of these flaps that I fashioned. Hoffman pocket is perhaps easier to fashion for those who are not used to creating a scleral flap, wherein the pocket is created just like a scleral tunnel, partial thickness, and then the knot is buried into the pocket, and so the knot is again not exposed beneath the conjunctiva and does not cause conjunctival erosion and thus foreign body sensation. So moral of the story, I think sutured SFIOL is a safer and sturdier option because we've had previous 5-year studies which show us the safety of this procedure, and if done well, perhaps this can be our go-to technique in cases where the bag or the zonules are not there. Thank you.